Hi, everyone. Thank you so much for joining us today. My name is Tamar Katz. I'm a child psychiatrist, and today we're going to be talking about management of pediatric depression. So without further ado, why don't we get started? Okay, so as I said, today we'll be talking about how to manage pediatric depression. And pediatric depression is an increasingly common thing that we're seeing across specialties and something that unfortunately we all need to learn how to manage with increasing prevalence. So I have nothing to disclose for the purposes of this talk. Just to tell you a little bit about who I am a child and adolescent psychiatrist at Boston Children's Hospital, and I've also done extra training in neuropsychiatry. So I do about 50% of my time treating bread and butter child psychiatry, including obviously seeing a lot of depression, and 50% of my time treating medically complex kids who have overlapping neurological and psychiatric issues. And one of the things that I see is not only in my mainstream psychiatry practice, but also in my medically complex population, I see increasing rates of depression. And this leads me to believe that not only am I seeing this, but I'm sure that subspecialists across the board are seeing increasing rates of depression in neurology, primary care, other subspecialties. And I think this is probably something that we all need to become increasingly comfortable diagnosing and managing, because unfortunately it is on the rise. So the objectives for today's talk are exactly that: to help us understand recent trends in the diagnosis of pediatric depression, to clarify the diagnostic parameters for depression and feel increasingly comfortable diagnosing it, and how those symptoms can be correlated with depression or with other diagnoses, and how to distinguish between when this is and is not depression, to recognize risk factors for aggression and safety concerns and when to refer to a higher level of care, to understand treatment of major depressive disorder. And then, of course, at the end, we'll touch on some trends in suicidal ideation and how to manage suicidal patients, because that's obviously something that's important for all of us. So an overview for today's talk: we're going to talk about the prevalence of pediatric depression, which is unfortunately increasing across the board, irritability and aggression as symptoms of depression, in addition to the basic diagnostic criteria, which we'll go through, and how to distinguish between major depressive disorder, ADHD, bipolar disorder, various mental health conditions that can present with overlapping symptoms, and how to know what's what, treatment of depression, adolescent suicidality, including recent trends in suicidal ideation, how to develop a safety plan for suicidal ideation, and then how to create a team to manage suicidal patients and what to do with those patients. So let's start by talking the prevalence and screening of depression. So there was a paper published in 2016 that looked at the trends of major depressive episodes. And what the study found was that between the ages of 2005 to 2014, there was a significant increase in the prevalence of depression in children ages 12 to 25. So the way that this study was done is, this is data from 2005 to 2014 from the National Survey on Drug Use and Health, which is an annual phone survey that's conducted. And the N for this study was 172,000 children between the ages of 12 and 17, and 178,000 children, or young adults really, between the ages of 18 and 25, which are technically adults, but we also think of them as transitional age youth, that transitional phase between childhood and adulthood in child psychiatry. And what they found is that particularly in the younger population between the ages of 12 and 17, there was an increase from 8.7% in the prevalence of depression in 2005 to 11.3% in 2014. So, over a 30% increase. And in age 18 to 25 population, there's an increase from 8.8% to 9.6%, which is a smaller increase. Although what's interesting about this data is that almost the entirety of that increase was in the population between the ages of 18 and 20. There was not a lot of increase between 20 and 25. So again, it seems to be the younger population where the prevalence is increasing. So between the ages of 12 and 20, there was a statistically significant increase in the prevalence of depression. Now, just to describe some of the limitations of this study, this data is gathered by, it's a phone survey, so it's a self-rating questionnaire, and the diagnostic criteria were the DSM-5 diagnostic criteria, and patients had to have met diagnostic criteria for a major depressive episode in the past year. So, there were some limitations in terms of it being self-rating, but what they did find was, even after the data was corrected for substance use, socioeconomic status, that nonetheless these rates of depression seem to be increasing across the board for children ages 12 to 20. And, this is obviously concerning. This is something that we are seeing more and more of and that we need to learn how to treat. And in fact, it's estimated that depression nationally is one of the most, if not the most, debilitating mental conditions. So the highest number of days of missed school, days of missed work, loss of functioning is due to depression over any other medical condition. And what the study found in addition is that while the rates of children receiving treatment for depression were fairly stable between 2005 and 2014, the type of care was changing, suggesting that there was increasing severity. So more children were seeking treatment in specialty mental health care centers, such as with a child psychiatrist or private mental health care clinics. The number of inpatient stays increased, suggesting higher severity of cases. And keep in mind, that's with the number of inpatient beds decreasing, right? So there are more children accessing inpatient care, even though there are fewer beds out there, again, suggesting increasing severity. And the number of children seeking day treatment options being treated in day treatment centers, such as partial programs, also increased. As well, the percentage of children receiving prescription medications. So whereas 16% of children were prescribed antidepressant medications in 2005, 20%, so again, a 25% increase, were being prescribed antidepressant medications by 2014. And in particular with this data, what I want to highlight is the data around the inpatient stays. So in 2004, they found that 3.1% of children who were diagnosed with depression ended up on an inpatient psychiatry unit. And by 2014, that number had increased to 5.5%. So not quite double, but not far off, which suggests again that the severity of depression is also increasing in addition to the prevalence, and children are needing more aggressive treatment and management of depression. So let's think about how we diagnose depression. I think everyone has at some point in their medical training probably come across the DSM-5 diagnostic criteria, but it's always helpful to go through them. So the way we diagnose depression is by looking at not only depressed mood, but also what we call neurovegetative symptoms. And neurovegetative symptoms are a number of symptoms listed here on the left, which we lovingly refer to as the SIGI caps, right, which is the mnemonic. And those are things like impairments in sleep, either sleeping too much or not enough, a change in interest level, so what we call anhedonia, where things that used to be fun and joyful are just not fun anymore. There's no joy in anything, there's no fun. Even in an amusement park, the child can't enjoy it, and it always seems like everyone else is having a better time than they are. Chronic feelings of guilt, low energy that can often impair functioning, impaired concentration, so just thinking slowly, processing slowly, or being very distracted, having a tough time concentrating. Changes in appetite, and this can be eating too little or eating too much. Sometimes children also tend to binge eat and use food as a source of comfort. Psychomotor retardation, where the child just feels like everything is slow, their body's heavy, everything feels more effortful. And then suicidal ideation, where of course we start worrying about safety concerns. And in order to meet diagnostic criteria for depression, a child must have depressed mood and actually feel sad. But in addition, they have to have at least 5 of these 9 neurovegetative symptoms for a period of, most of the time, for at least 2 weeks. So the majority of days over a 2-week period. Now, of these diagnostic criteria, we find that the most highly correlated is not only depressed mood, but also this one, anhedonia, so loss of interest, where there are many reasons a child might have a change in energy, a change in concentration, a change in appetite, especially again in medically complex kids who have other medical comorbidities, or a lot of psychosocial stressors going on. This one, anhedonia, when nothing is joyful, nothing is fun, and a depressed mood, those can be high diagnostic indicators of depression. And as with all mental health conditions, these symptoms need to cause distress and impair functioning. So those are the basic criteria for diagnosing depression. And to make it easier, there are some statistically validated screening tools that we use, less so. Some mental health clinicians use these. Many of these are designed really for primary healthcare providers for whom time is of the essence, or for non-psychiatric specialists, although certainly people within the field of psychiatry also use these screening tools. And this is, some examples of them are the PHQ-9, the Patient Health Questionnaire 9. It's a 9-question self-rating scale where patients rate themselves on a scale of 0 to 3, with 0 being not experiencing symptoms at all, and 3 being experiencing symptoms every day, and then 1 and 2 are varying levels of frequency. And it essentially goes through those neurovegetative diagnostic criteria. So you can see little interest or pleasure in doing things, feeling hopeless, poor appetite or overeating. Down here, suicidal ideation. It goes through all 9 of the neurovegetative symptoms that we looked at on the last slide. And just to give you a sense of the cutoff, a PHQ score of 5 would be considered diagnostic, or not diagnostic, but a a screening assessment for mild depression. A score of 10 would be moderate depression, 10 to 15 would be 15, let's say, would be moderate to severe, and a score of 20 would be severe depression. So this is just a self-rating scale that has been shown to be reproducible in its accuracy that patients can use as a screening questionnaire for depression. But even faster than that, as I said, what we found to be most highly correlated are depressed mood and anhedonia, that lack of joy or enjoyment of any activities. So there's an even quicker version called the PHQ-2, the Patient Health Questionnaire 2 screening instrument for depression, that asks simply those two questions and has shown nonetheless to identify patients either with depression or at risk for developing depression. And those two questions are little interest or pleasure in doing things, anhedonia, and then feeling down, depressed, or hopeless, so depressed mood. And again, it's a self-rating scale from 0 to 3, ranging from not experiencing symptoms at all up to experiencing symptoms nearly every day. And a score of 3 would be considered a positive result. And this is a way to help clinicians identify patients at high risk of depression and flag patients. And I certainly, if you're not using these, this may be a good thing to ask patients to fill out. They can fill it out even in a matter of moments while they're sitting in the waiting room. And this at least can put a patient on your radar, whether depression is something that you need to be thinking about during the visit. So one thing that I do want to mention is that pediatric depression is a little bit different than adult depression. So we still diagnose it the same way in our DSM-5 criteria, where we look at the neurovegetative symptoms and we have to diagnose at least 5 of the 9 SIGI CAPS criteria. But one thing that we find increasingly with pediatric depression is that unlike adult depression, which often presents with this very sad, withdrawn, staying in bed, not getting up, not functioning, which is how we often think of it. In pediatric depression, what we find is that irritability is present in the majority of cases. And over about 80%, up to 80% of cases of major depressive disorder in children present with irritability as a presenting symptom. And funnily enough, we often think of irritability as being something that patients can experience in bipolar disorder. So certainly patients with severe manic episodes can present with a very irritable, with labile irritable moods. But in fact, there's a study that was published, or a paper that was published in JAMA Psychiatry in 2013, where they found that actually unipolar depression presents with higher rates of irritability than bipolar depression, and up to 80% of children with major depressive disorder present with irritability as the presenting symptom, compared to only 37% of patients with bipolar disorder. So just to highlight what the authors of that paper said, although symptoms of irritability or anger are not central to the diagnosis of unipolar major depressive episodes, again, it's not one of those 9 DSM-5 criteria, these symptoms have been found in cross-sectional studies to be highly prevalent and associated with increased depressive illness burden. So one of the things that we've tried to do in the field of child psychiatry in order to make our diagnoses ever increasingly accurate is there's been the creation of a new diagnosis, which is sort of a sister of depression, and that diagnosis is called DMDD, Disruptive Mood Dysregulation Disorder. And this has been a way that the field has tried to better explain irritability as a chronic symptom of depression, whereas in the past those kids would often get diagnosed and in many cases misdiagnosed with pediatric bipolar disorder, which is now we're realizing a lot less common than was previously diagnosed. Now we realize that a lot of those symptoms are in fact symptoms of depression. So DMDD is a fairly recent diagnosis where patients will present with a depressed mood and baseline dysphoria with very severe irritability superimposed on top of that. So to keep in mind, many adolescents are irritable. Puberty in and of itself with all the hormonal fluctuations can cause irritability. Parents will often complain that their teenager is difficult and irritable. But what we want to parse out is what is considered typical irritability for a teenager and what is really crossing a line where maybe we're thinking of this as a teenager who's being difficult, but in fact depression should be on our radar. So for a diagnosis of DMDD, the outbursts, the diagnostic criteria suggest that the outburst should be grossly out of proportion in intensity or duration and inconsistent with developmental stage. So again, many children can have outbursts for a lot of reasons. Kids with developmental delay, kids with autism, kids with various genetic syndromes. There might be many reasons why a child is having outbursts. It doesn't necessarily suggest that they're depressed. So keeping in mind their developmental stage is very important. But if the outbursts are grossly out of proportion in intensity and in duration, then that maybe is a red flag to us that something else is going on here and could belie an underlying depression, because that can often be the presenting symptom of irritability. Outbursts have to happen at least 3 times a week. The child is experiencing persistent dysphoria, so that depressed mood, and it has to be present in at least 2 settings for a minimum of 12 months. So there are some kids who are very irritable at home, but at school are the life of the party, lovely, all of the teachers love them. That might be a little bit less characteristic of DMDD or major depression would suggest that there's more of a modifiable component there. So this was a diagnosis that I just want to highlight particularly because many people have heard of major depressive disorder but have not necessarily heard of DMDD. And I want to make sure that it's on people's radars. You may be seeing more of this diagnosis as we better understand the link between depression and irritability. This was, again, designed to more accurately identify children previously misdiagnosed with bipolar disorder. And interestingly, with DMDD, these kids often, even with treatment, some of the irritability will subside, but many of them, to some extent, continue to have this chronic dissatisfaction, but it does not develop into bipolar disorder, and there's no direct correlation between having DMDD and developing bipolar disorder. So just to think about some of the diagnoses and how to distinguish between major depression and other diagnoses, knowing that many things can present with irritability, I wanted to just highlight 3 diagnoses here that commonly overlap and often are misdiagnosed one for the other. So I've put DMDD in the central category, but again, that also encapsulates classic major depression, unipolar major depression. So when we think about major depression or DMDD, the episodes can be severe and the irritability as a presenting symptom can be severe, and often it's just chronic irritability. The kids just persistently feel frustrated, irritable, sad. Unlike ADHD, where kids can present with irritability, but it's more defiant, and it tends to, as I mentioned down here, in between outbursts, it tends to resolve. So kids will be very headstrong and might have tantrums in ADHD and be very cognitively rigid, but that tends to resolve, and in between their mood often returns to a fairly happy baseline. With DMDD, the kids are chronically dissatisfied. The major depression is just an ongoing, lingering experience if it's not being treated, and the irritability is fairly persistent. And on the other hand, this is in contrast to something like bipolar disorder, where the kids might have mood symptoms or irritability, but they tend to be more episodic. They'll have discrete manic episodes that then resolve to baseline. They may have discrete depressive episodes that, if treated, should cycle and resolve to baseline. But again, in between, there's some happy mood or some stable mood that they resolve to. Age of onset can also be another way of helping guide us as to where the diagnosis lies. ADHD, in order to meet criteria for ADHD, symptoms have to be there prior to age 12, and symptoms typically set in and are diagnosed between the ages of 4 and 12. With major depressive disorder or DMDD, it tends to be more from the ages of 6 to 18. So tween years, teen years are really high likelihood of first onset of depression. And in bipolar disorder, for true bipolar disorder, the age of onset is typically in later years, like in the early 20s. It would be very uncommon for a child to develop true bipolar disorder at the age of 8 or 12. Major depression disorder and DMDD can present with some psychotic symptoms. It's not common, but you can get an affective psychosis, psychotic depression. It's also called major depression with psychotic features. ADHD absolutely should not have psychotic symptoms. So if you have a child who is presenting with irritability and defiance and is having psychotic symptoms, it's unlikely to be ADHD, or at least not ADHD alone. And then in bipolar disorder as well, psychotic symptoms can be present. They do present quite differently. Major depression has the neurovegetative symptoms, that irritability with ongoing persistent dysphoria. As I said, with ADHD, often their energy is fine, their sleep is fine, concentration is fine. They might have irritability and tantrums, but those tend to resolve in between. And then bipolar disorder on the other side looks quite different. Patients will present with grandiosity if they're manic, loosening of associations, high increase in risky behavior. Their depressive episodes will look fairly similar to major depressive episodes, but they should have at least some manic episodes to meet criteria for a diagnosis of bipolar disorder. And irritability alone would not be enough to meet those criteria. So irritability alone, again, is much more suggestive of major depressive disorder. And the reason that I'm focusing on this, and that I think it's really important to put it on our radar, is many parents will come in and tell us that their child is very irritable. And I think often we think of this as, oh, teenagers are irritable, oh, this is puberty, oh, this is just the parent-child interaction. And I think it's really important that this be on our radar as a presenting symptom of depression, because it may be something that we're missing in a lot of kids. And it could belie an underlying major depressive disorder that we can treat and help them improve. So again, just to sum up, if you have chronic basal irritability, that would be more suggestive of depression. If it's episodic and severe, that would be more mania. And then if it's just headstrong, defiant behavior that resolves, we think more of ADHD. The reason, again, that irritability is so important to think about is because it can progress to aggression, and we want to make sure that we're keeping everybody safe. So if the irritability is so bad that there's physical aggression involved, then we especially want to be thinking about something like major depressive disorder or an underlying mental health condition, and you would want to refer to a mental health specialist at that point. So how do we treat depression, right? We're all seeing increasing rates of depression. This is something that we need to know how to treat. And I think it's important to realize that there aren't enough child psychiatrists out there, unfortunately. As many of us know, you can wait months to get connected to a mental health clinician or to a child psychiatrist. And so it's really important that we be able to treat depression, I think, with increasing comfort level, even as non-psychiatric providers. So how do we treat depression? I'm going to take you through some of the treatment protocols that we use. So before we go into the actual details of treatment, what our treatment is based on is, this was a study in JAMA 2004. This is called the TAD study, the Treatment for Adolescents with Depression study. And what the study did was it randomized patients into 4 groups: placebo, fluoxetine alone, which is an SSRI, CBT, which is cognitive behavioral therapy alone, and then fluoxetine plus therapy, fluoxetine and CBT. So again, placebo alone, medication alone, therapy alone, and medication and therapy, in this case, an SSRI and cognitive behavioral therapy. And this was a study that was done on 432 teenagers across 12 sites, ages 12 to 17. And the outcomes were measured using the Children's Depression Rating Scale. And the way that this was done was that children met with independent interviewers who were not aware of the child's treatment status within the study. So the interviewers were blinded and the patients themselves were blinded. And what they found is that in the short term, there seems to be, placebo actually interestingly does have a pretty important impact, which suggests really the significance of the placebo effect. And that's a whole interesting discussion in and of itself. But there is something about believing that you're being treated and that you'll get better that certainly helps with depression. And I think also in the way that we approach patients, this is a really helpful thing to keep in mind, that when we provide treatment, instead of saying, well, if it works, then such and such, I now have modified my language based on the study to say things like, when you feel better, you'll notice such and such, or when the medication kicks in, because when patients believe that they're getting treatment, actually in and of itself, that can be a therapeutic intervention. So just as a sidebar, that's an interesting thing to keep in mind. But when we look at the actual other treatment arms, medication alone, therapy alone, and medication and treatment, what we found is in the short term, medication has a statistically significant rate of higher remittance than therapy alone. When they followed the patients out over 36 weeks to the endpoint, interestingly, the fluoxetine and therapy arms had very similar rates of remission of symptoms, both 81%. So over time, therapy and medication, if you're going head to head, are equally effective if you have time. If we need to get a patient under control in the short term, for example, as I said, if there's significant irritability that's causing aggression, if there's a real decline in functioning, and we need to just get a patient feeling better as quickly as possible, in the short term, medication had higher rates of remittance than CBT alone after 12 weeks. But the best effect came from the combination of medication and therapy. So fluoxetine and therapy had a rate of remittance of 71% compared to only 61% for medication alone and 43% for therapy alone. And over time, after 36 weeks, also had higher rates of remittance than either of those 2 arms alone. As you can see, over time, interestingly, the difference lessens. It's 86% compared to only 81%, but it was still statistically significant. And we were talking about, every child is a child that feels better. So it's something to keep in mind. So the take-home message from the study was that medication and therapy seems to have the highest combined effect as opposed to either arm alone. And when they looked at the level, so this was based again essentially on the DSM-5 diagnostic criteria. But when they looked at other criteria suggesting level of functioning, like missed days of school, parent rating of how the child was doing, compliance at home, attending work, doing chores, keeping up academically, taking care of showering and self-care and all of those types of functioning, what they found is that the level of functioning in the TAD study, they also saw the highest rate of improvement in the combined treatment of fluoxetine and therapy. So if you look at this line up here, this shows improved functioning in fluoxetine and therapy together. Next was fluoxetine alone had a higher improvement in functioning than therapy alone. Therapy did not separate out from the placebo when you looked at functioning. And this was measured by utilizing the CGAS score, which is a scale we use for measuring functioning in patients with mental health issues. So how do we treat depression? I think this is a really important thing to think about, right? We've talked about how to diagnose it. We've talked about why treatment is important, but how do you actually treat it? Because again, this is something that we need to know how to treat. Okay, so the first thing that we do based on the TAD study and based on some other studies that we don't have time to present today is we start with an SSRI. So the two that have been FDA approved that have been studied in randomized controlled trials are fluoxetine and Lexapro, also known as escitalopram. And that would be the first go-to medication. We also use sertraline very often, which is another SSRI. It has not been FDA approved because there was not a randomized controlled trial to study it. But based on the results from fluoxetine and Lexapro, we understand broadly that the class of SSRIs is safe and effective, and it's something that we use for treating depression. So I didn't list sertraline on here since it's not FDA approved, but we also will use that. So my first go-to is to start a patient on an SSRI. And one of two things can happen, or one of three things. Either they'll have full remittance of symptoms and we'll get up to a therapeutic level of the medication and we'll be monitoring. You can use the PHQ-9 over time, that assessment scale that we talked about at the beginning, to monitor symptoms over time, or you can do your own interview. But either way, some patients will improve with the first SSRI trial, and that's terrific, and they stay on that medication, and that's great. The other two things that can happen is one of two things. You can have partial improvement, where a patient will have partial remittance of symptoms, or no improvement at all. In that case, if a patient does not improve, I will cross taper to a second SSRI. So again, if I used fluoxetine, I might switch to escitalopram or to sertraline. And I often choose based on the patient's presentation. So fluoxetine tends to be a little bit more activating. It gives patients a little bit more oomph, gets people up and going. So if I have a patient who's very low energy, not functioning well, I might choose fluoxetine because it's a little bit more activating. On the flip side, sertraline, for example, is more calming and sedating, and it's thought to have a little bit of a superior edge for managing anxiety. So if I have a depressed patient who has a lot of anxious distress and is very anxious and wound up, or is having trouble sleeping, for example, I might use sertraline because it's actually quite calming. It's the opposite of Prozac, and I may want that side effect benefit for that patient. And then Lexapro, I would say, is somewhere in the middle. It's not particularly activating, it's not particularly calming, so I'll often use it as a good middle of the road agent for patients who aren't in either of the first two camps. So if I'm not seeing any improvement, I'll cross taper to a second SSRI and give that a shot. If I'm seeing partial improvement, where a patient has had 50% improvement, but we're now up to the max dose of the SSRI, I don't want to lose that benefit. So what I'll do is I'll augment with Wellbutrin or Abilify. If I add low dose Wellbutrin, maybe 150 milligrams daily, or Abilify 5 or 10 milligrams once a day, often Abilify and Wellbutrin, because they act through a different mechanism, there's a synergistic effect where they can boost the effect of the SSRI, and we see improvement in the patient's response rate. And that's true whether it's my first SSRI trial or my second. So if I'm seeing partial improvement on an SSRI, I will keep the SSRI in place, but I'll augment with Abilify or Wellbutrin. But what if I try 2 SSRIs and I don't see any improvement? What do I do at that point? So if I'm not seeing any improvement, at that point, I'll switch classes. I can either switch to a totally different class of medications, not out of the SSRI class. So Wellbutrin, which is more dopaminergic, for example, or mirtazapine. These are 2 antidepressants that are not SSRIs. And I'll often find that patients who don't do well on an SSRI may do better on one of these. Or I'll switch to an SSNRI, like Effexor or duloxetine. And similarly, if I switch to one of these classes and it doesn't work, I really should have put a bidirectional arrow here. You know, if a patient has gone through 2 SSRI trials, has tried Wellbutrin or mirtazapine or Effexor or duloxetine, and it hasn't worked, I might switch to the other class here. So if I tried Effexor, maybe I'll switch to Wellbutrin. And keeping in mind, especially based on the TAD study and on other studies, we know that therapy is a huge adjunct to this. So I want to highlight that for patients, though I may be bridging medications, I always recommend that they be in therapy concurrently, because we know that the best effect is the combined effect of therapy and medication. And what I want to highlight about that also is that even though the TAD study showed that CBT, cognitive behavioral therapy, was the type of therapy that was studied, in general, studies show that it's therapy in general that seems to have the biggest effect. So cognitive behavioral therapy is great and very high yield for depression, but actually it's really just the therapeutic alliance and having a therapist that you are bonded with, and that relationship over time of being able to work on issues, whatever the approach that the therapist is taking, that actually is shown to be equally beneficial. So if a patient already has a therapist and they're in DBT or supportive therapy, often just having a therapist in and of itself is a very helpful thing. They don't necessarily have to switch to cognitive behavioral therapy. So I think the take-home message is, you know, this is a treatment protocol for depression, but certainly always encouraging therapy concurrently. I do want to take a minute and touch on mood stabilizers, because I think, especially given that many of the people attending this talk are neurologists, and that's a class of medicines that many neurologists are comfortable with because of their anti-epileptic properties, it's something that I just want to discuss for a minute. So for some reason, though we often use mood stabilizers in adults, randomized controlled trials in children have not shown a huge statistically significant benefit. For whatever reason, we have not been able to have proven efficacy of mood stabilizers in children. Certainly, yes, for anti-epileptic properties, but not so much for the mood stabilizing properties. I will tell you that anecdotally, off-label, if a patient has not responded to all of these different antidepressant medications, I often will try a mood stabilizer, and I do find that it can have mood stabilizing properties. I'm not sure why it is, from looking at the studies, that it just has never been reproducible on a broad scale, excuse me, in the studies. But certainly for, certainly there are patients who do respond, and it's something to think about if you've tried. But I think starting with the classic antidepressant treatments is more helpful. In patients with comorbid seizure disorders, because we don't want to reduce polypharmacy, for those patients also, I may choose to optimize their mood stabilizing. I may opt to pick an anti-epileptic that also has mood stabilizing properties, for example, and bypass some of the antidepressants just in an attempt to reduce polypharmacy. And it's sort of hit or miss whether it works for that patient. In terms of treatment of aggression, risperidone and Abilify are both FDA approved for aggression. So if you have a patient who is irritable to the point of being aggressive, and obviously we want to treat the underlying depression because we think that's what's causing the irritability. But if we're worried about aggression as a symptom in and of itself, even if it's caused by depression, sometimes what you need is something just to manage the aggression. Low-dose risperidone and Abilify are both FDA approved. And something like, depending on the age and size of the kid, 1 milligram twice a day might be a reasonable thing, half a milligram, even up to 1.5 milligrams. Abilify, again, 5 to 10 milligrams once or twice a day. I just want to touch briefly on the neurobiology of depression before we move on. So one thing that's really important to keep in mind is that even with all of our current treatments, in adults, we know that 50 to 70% of adults do not experience full remittance of symptoms, even with treatment. And obviously that's a really high number. Depression is the number one diagnosis for lost functioning in the United States of America, and I think possibly internationally as well in certain other countries. And, there's a lot of really debilitating effects of depression. And unfortunately, our treatments are very helpful, but not perfect. So though people will often have partial remittance of symptoms, as I said, 50 to 70% of adults don't have full remittance of symptoms. And we don't know exactly what the numbers are in children. I think the data's still out on how many children, but certainly it's not 100% of children who have remittance of symptoms. So it's helpful to think about the neurobiology of depression, because as we move forward and develop new therapeutic strategies, we need to think about where in the brain this is happening. So I want to just touch on that briefly. The areas in the brain that have been most highly shown to be implicated in depression are the prefrontal cortex, the anterior cingulate cortex, and the networks that they share with the limbic system, including the amygdala and the hippocampus. So these frontal subcortical networks are most highly implicated in depression, and they show impaired functioning on functional fMRI studies. One other area of the brain that's highly implicated, that's a fascinating area of the brain really, is the insular cortex right here. So the insula is the part of our brain that helps us take our own internal temperature, so to be aware of our own internal feeling states, and also to respond to the feeling states of others. So taking the pulse of the room, if someone responds to you calmly, you respond calmly back. If someone is yelling at you, it makes you upset and has you respond more angrily to them. And a lot of that is controlled by the insular cortex and networks that involve the insula. So these are the regions of the brain that are most involved in major depressive disorder, and just wanted to touch on that before we move on. Okay, so now what I want to talk about is management of suicidality. We've talked about how to diagnose depression, we've talked about how to treat depression, but something that I think should be on all of our radar is suicidality. And the reason for this is because we know that the rates of suicidal ideation are increasing, which we're going to talk about in a minute. And I think all of us as clinicians have probably had that experience, or many of us have had the experience of a child who endorses suicidal ideation in our clinic, and suddenly the whole afternoon is shot, right? You have to think about how to keep this child safe, refer them to the emergency room, get in touch with the parents. And it's something that we really need to know how to manage and how to think about, because I think all of us, our anxiety goes up when we hear about a child who's suicidal, and I want to make sure that we're addressing it in the talk today. So when we think about the trends of suicidality, I'm not sure how many of you saw this. In 2019, there was a letter that was published in JAMA Pediatrics. And what this study did was they drew data from the National Hospital Ambulatory Medical Care Survey, which is a database that's collected by the CDC. It's a nationally representative sample collected annually by the CDC, National Center for Health Statistics, in which they look at all of the ED visits across the country and why people are coming to the ED, what they're receiving as treatment, diagnoses, discharges, as a way for us to get a pulse on, I guess, medical concerns nationally and ED usage. And what this study did in JAMA Pediatrics was they randomly sampled 300,000 ED visits between the years 2007 and 2015, of whom 60,000 were for children. And when they looked at the children, they were looking at children ages 5 to 18 years, and they looked at children who had a discharge diagnosis of suicidal ideation or a suicide attempt. And what they found was a quantitative increase over time in the prevalence of suicidal ideation as a primary presenting symptom to the ED or a discharge diagnosis. So in 2007, there were 580,000 kids based on the database who presented with a suicidal ideation or suicide attempt and who had a discharge diagnosis of such. And by 2015, that number increased to 1.12 million, so almost a doubling in the number of cases. And the percentage visits for suicidal ideation or suicide attempts also increased a statistically significant amount from 2.17 in 2007 to 3.5% in 2015. So again, a 50% increase in the percentage of patients, the total percentage overall of patients presenting for suicidal ideation or suicide attempt. So this is obviously very, very concerning that the prevalence of suicidality is going up, and we're probably seeing this in our clinics. We're certainly seeing it in the emergency room, and we need to know how to manage it. And this is important because suicide is the second leading cause of death in children. So the risk is real. The first leading cause of death is accidents, all cause accidents, and the second leading cause is suicidal ideation, suicidality, I guess, not ideation, suicide attempts, and suicide itself. So this is really concerning. The lifetime prevalence of suicidal ideation is 12.1%. 4% of the kids will actually have a suicidal plan, and 4.1% will go on and have a suicide attempt. And what we see is that when we look at the change over time, I want to highlight this blue piece of the pie here. 60% of the patients who have suicidal ideation will have a more premeditated experience where they'll go on to develop a plan and then have a suicide attempt. The other 40%, so over a third of patients with suicidal ideation, will have an impulsive attempt where they don't necessarily have a plan, but they'll impulsively attempt suicide. So when patients endure suicidal ideation, we need to take it seriously because adolescents are impulsive, children are impulsive, and they don't always have a plan, and sometimes suicidal ideation can be the warning sign that something is going to progress. So, again, just to highlight, 40% of the time, suicide attempts are unplanned and impulsive. So thinking about some of the risk factors for suicide, how can we be mindful of which kids are at higher risk than others? So these are some risk factors for suicide that I want to go through. A known family history or exposure to suicide attempts, right? Children model what they see. So if they have a close friend or a close relative who's suicided or had a suicide attempt, that certainly is something that puts them at increased risk. Family history of mental illness can put them at increased risk, both biologically, because they themselves are at higher risk of mental illness, and that can be a factor, or because it means they don't necessarily have the support around them. The child of parents who are struggling with mental illness may not be getting the same psychosocial support. And then, if the parent is in a moment of struggle, it's hard for the child to see the parent going through that struggle, and the child themselves may not necessarily be able to have the support they need in that moment, or from a sibling or whatever it be. Family history of mental illness is certainly places kids at increased risk. A personal history of prior suicide attempts. So if a child has had a suicide attempt before, they're much more likely to attempt again because they've already crossed that line and have a certain comfort trying something like suicide. So that certainly puts them at increased risk for trying again. The likelihood that self-injurious behavior leads to suicidality is actually contested in the field. It's hard to know. So studies seem to say that it does. Other studies say that it doesn't. Certainly it's a suggestion that the child is not doing well. And it's something that at least should be a little bit of a red flag if a child is self-harming. Whether it really increases risk for suicidal ideation is a little bit unclear. Psychosocial stressors like bullying, financial instability, cultural differences of children who may be struggling with mental health issues, but parents' cultures are not very accepting of that, or even if they are accepting, just the tension of, let's say, being an immigrant from another culture and adapting to American society, children struggling with sexuality, which is increasingly common, academic pressures, which is increasingly common. Another big risk for suicidality is recent psychiatric hospitalization. So studies have shown, I didn't include the data today, but studies have shown that there's a very high increase in the risk of suicidality in the first 6 months after being discharged from a psychiatric hospitalization. So if you're inheriting a child who was recently discharged and you're following them after discharge in your clinic, you want to be checking in for suicidal ideation. And a big factor, of course, is access. So patients who have access to a gun, patients who have access to unlocked medications, patients who have access to knives in their house, all of those things can, of course, increase the likelihood because access is a factor in all decisions. So what do we do, right? If you have a child who's endorsing a clear plan and does not feel able to keep themselves safe, we want to refer them to the emergency room so that they can be hospitalized and managed and get care. But many patients might report suicidal ideation and they don't necessarily have a clear plan. Granted, as we talked about, not having a plan is not a safeguard per se for suicide, but the patients feel that they are able to keep themselves safe and they recognize that suicidal ideation is something that they are living with, but that they feel that they can keep themselves safe and they're not necessarily likely to act on it. So what we want to do is really build up that sense of safety. And one of the things that I often do with patients is create a safety plan. I've included here just an example safety plan. There are many versions out there. You can certainly go on Google Images and find some, or your own home institution may have materials that it uses. And what we want to do is, just as with any other situation, thinking through what a backup plan is, how you're going to react, what some options are to keep you safe. Essentially, that's what a safety plan is. So the first thing I do is I sit down with kids and I talk through, okay, if it gets worse, how are we going to know if you're becoming unsafe? What are some warning signs of a crisis? So those can be things like, I withdraw and I stay in my room. I stop showering. I find that the suicidal thoughts are getting more and more severe. I start developing plans. I find myself having crying episodes all day. These can be warning signs that we're on the brink of a crisis. And if any one of those things were to change or were to occur, then I know that I'm no longer safe and I want to reach out to someone. People I can call for help. So again, we always say you don't learn to swim on a stormy day in the deep end of the pool, right? You want to learn to swim when it's calm and the weather's beautiful. Safety planning is the same. So when the child is in my office and they're feeling a little bit better and they're doing okay, that's when I want to sit down and make a list of, if I do feel unsafe, who can I call? What is their phone number? How can these supportive people help me stay safe? So some suggestions of, when I do call my mom or dad, or I do call my teacher or my cousin or my neighbor, what can they do to help me stay safe? What are some things that I know work well for me? Some breathing techniques, distraction techniques, phoning a friend, watching a TV show, exercising, taking a shower, just changing the scenery and going to a coffee shop or going somewhere different. Things that I know help distract me and help me keep safe. Some activities that I can do by myself to try to take my mind off things. So if I'm not able to reach one of those supportive people, again, from that list that I just mentioned, how can I keep myself safe? And some strengths. I think it's always really important to take a strength-based approach because it's really hard for the kids to feel good about themselves. So reminding them, like, you have a lot of strengths and we want to build on them. And what are some things that you're really good at that we can build on to help you get by? What are hobbies that you have, friendships that are meaningful that you have, sports teams you can become more involved in, opportunities for mastery, different things that the child is good at and helps them feel good about themselves. And I think just sitting down with the child, what this really does is, it's not that any one of these suggestions is going to mitigate against suicide, but what can be really helpful is just for the child to have a format to discuss this with you. So if you're not comfortable talking about suicidal ideation with the child, this is a safety plan is a way to generate that discussion, and going through this sheet together can really help the child feel that you understand and help you feel that you have a format to talk to the patient about it. So it's a good way to get the discussion going and to better assess how much the patient is able to safety plan with you, and to design concrete suggestions at home for how to keep themselves safe, who to reach out to, how to stay busy and distracted. If a child can't do that and is really unable or unwilling to engage, again, that makes me more concerned that this is a child who needs to be referred to a higher level of care. If a child is engaged in safety planning, that can be reassuring. But of course, dealing with these things alone is never easy. So I want to go through how to develop a plan and a team around managing this, because another thing that's important is, just as the child needs support, we as clinicians need support. So what I always say is, I think it's really important to have a clinic plan. As a provider in the office, it's really hard if a child endorses suicidal ideation to have the time and the mental energy to help them. And so it's important to have an identified person in the clinic. And I encourage you to speak to the head of your clinic, the head of your department, the chair of your service, depending on how it works, or even if you're in a private practice, to think about a point person each day within the clinic who may have a lighter patient load that day and has time to deal with these types of acute issues that might come up. So it's important to have a plan and to have other supports in place. So number one, involving the parents. Sometimes the parents can be part of the problem, but helping them be part of the solution, understanding that this is a child who's suffering, having them provide extra surveillance at home is always really reassuring. Identifying other supports, so reaching out to teachers, neighbors, aunts and uncles, therapists, knowing that other adults are involved is also really important in helping a team develop around this patient. There are counseling centers that patients can go to. So some urgent care centers actually have psychologists or psychiatrists, and the patients can check in with if they feel that they need a more urgent visit. And here in Boston, for clinicians who are local, we have what we call the Boston Emergency Services Team, which is a mobile crisis team that can actually go out to patients' homes and check in on patients, assess things. They don't tend to make medication changes, but certainly they can refer patients to the emergency room if needed. And this is a service where I will often send patients home and then ask the best team to check in on that patient for support and making sure that everything is okay and safety while the patient is home. There are intensive outpatient programs, which can be day programs, either all day long for a couple of weeks, where the kids might be out of school and go to the day program if they need more intensive treatment. Or there are evening programs where kids can go to school and then attend a program from, let's say, 6 to 9 p.m. a few nights a week, just for extra support, extra therapy groups. And again, this is where a child lives at home and attends these groups, so the child needs to be safe at home, but it's an added level of support and developing support. So you are not the only person involved in helping this child, and the child has more support around them. And of course, involving schools. So if there's a psychologist at school, a guidance counselor, someone the child can check in with. If the schools need to be involved in lowering the academic pressure, maybe letting the child come in a period late in the morning so they can get some extra sleep or leave a little bit early, that's also really important. I think it's important as clinicians, even non-psychiatric providers, to think about bridge medications. So don't be afraid to start an SSRI if that's something you feel comfortable doing. We all know, unfortunately, in many parts of the country, even in Boston, the wait to see a child psychiatrist can be months. And these kids are often struggling, and we don't want to wait months to connect them to mental health treatment. So more and more familiarizing ourselves with how to start some of these basic SSRIs or how to change medications, even as non-psychiatric providers, can be really important. So I would encourage you to consider bridge medications, and don't underestimate the value of a committed, consistent, involved adult, even a clinician like you or I. I think sometimes what happens is in other parts of the child's life, they may have friends or family who either tell them to stop it and pull themselves up by the bootstraps, or, you'll be fine, don't worry about it. And if we as clinicians can really talk to them about it and make them feel heard and understand that we hear their fears, the way they feel now is not the way they'll feel forever, but we understand this is how they're feeling now. That kind of support and empathy can be really helpful and really hopeful for the child. So just being in it with them and being able to talk about these things. And again, I think that safety plan format is great just for generating discussion and having a way to discuss this with patients, which is not something that all of us are trained in or are comfortable doing. So don't underestimate the value of just having open discussion with the patient. And you might be the first person that they've disclosed their suicidal ideation to, and that's something that can be helpful for them. So just a couple of helpful resources for managing depression and suicidality. There's the GLAD PC, which are the Guidelines for Management of Adolescent Depression in Primary Care, which is a toolkit from the American Academy of Pediatrics, and I put some of the links here. There's the TAD study that I mentioned, the Treatment of Adolescent Depression study that we went through. There's JCAP, the Journal of the American Academy of Child and Adolescent Psychiatry Practice Parameters for Suicidality. So ACAP, the AACAP, American Academy of Child and Adolescent Psychiatry, has treatment protocols and practice parameters for a large number of mental health conditions, including major depression and suicidality, and those parameters can be helpful to look up. 3 other things I just want to put on the radar. There's a website called Psychology Today, psychologytoday.com, for those who aren't familiar, which is basically a listserv of therapists. So patients can go on, they can filter by their insurance, the diagnosis they want to treat, their location, their age, whether they want a male or female provider, et cetera. And it will generate a list of often several dozen, sometimes up to hundreds of providers based on that patient search criteria in their location who are able to see patients. Unfortunately, it's not always updated. So you may have a clinician who puts their listing up, says they're taking patients, but when you call them, they're actually full. So often I tell patients that they have to call down the list, several clinicians to find someone, but it's a great place to start. And again, it will generate a list of, many providers in their town or in their area who theoretically are able to treat them and can be a good way of connecting people to therapy, tying back with what we said before, that therapy is often as effective or certainly an important adjunct to medication treatment. There's a crisis text line, given that texting is the new thing. And I put the URL here. And of course, there's the National Suicide Hotline, which is staffed 24/7, and patients can always pick up the phone and call, and I put that here as well. So these are all helpful resources for managing depression and some referrals to give to patients. So just to summarize, the prevalence of depression and suicidal ideation, unfortunately, is increasing among children, and this is something that we need to be increasingly comfortable discussing and managing. Often it can present as irritability and at times aggression, which are in fact more highly correlated with pediatric depression than they are with bipolar disorder. So if a child comes in and irritability is really high on the list of the parents' complaints, please be thinking about depression, because that could be a red flag we don't want to miss. Treatment protocols are available to help guide non-mental health clinicians and of course mental health clinicians to initiate antidepressant medications. We went through some of those today, and the previous slide highlights some others, and I encourage you to take a look at those. And all clinicians can and should discuss safety planning and ask about suicidal ideation with depressed patients. So thank you so much for your attention. I really appreciate the opportunity to speak to this group. I want to especially thank Dr. Paige Partain for her suggestions and contributions to these slides. And these slides will be available. If you have any questions, please feel free to reach out to me. I've put my email address on the bottom. And again, thank you for your time and attention. And I hope that this was helpful.